Okay, great. Thank you so much for having me. It's a pleasure to be here. So 7 years ago, I was invited to give a talk here, actually, about telemedicine in the ER. While prepping to be here today, it excited me to think about how much has changed since then. So today, I'll be giving a version 2.0. I'll give a brief recap of how we got here, where we are today, and what's next. So it may come as a surprise that telemedicine was actually being practiced in 2017. Back then, telehealth visits were primarily for minor conditions at that time, and only a small segment of physicians were practicing telemedicine. Now, at that time in 2017, less than 1% of all physician-patient encounters were via telehealth. And the annual revenue for US telehealth companies in 2017 was about $3 billion. So when I presented here in 2017, I was talking about the work we were doing with Express Care, which was one of our first journeys into digital health. Now, why, if you were already physically in the emergency department, would you want to see a physician virtually if you're in the emergency department? And that was the question. And if you look at the slide, this is an article in New England Journal Catalyst in 2017 where we came up with this idea. And the Wall Street Journal actually wrote a story on this program back then. Now, our Express Care program allowed patients with minor conditions. Now, these aren't heart attacks, these aren't strokes, these aren't your really sick patients. But if they had a minor condition, to come into the ER and then connect virtually with a physician. Once again, people ask, why would anyone want to do that? Well, the goal of the program was really to shorten the wait times for emergency care, but also provide top-level medical care. And it also allowed our other physicians to then focus on some of the more serious conditions that patients came in with. Now, several years later and thousands of visits later, the data shows that this is a safe and efficient means to provide care in the emergency department. So around the same time in 2017, I co-authored an article in JAMA on the need for the medical virtualist. So you might ask, what is the medical virtualist? So we define the medical virtualist as a physician who spends majority of their time providing virtual care. Now, this article in 2017 was well received, but I will tell you, many people thought that it was an overestimation on the role that telemedicine would play in the future of healthcare. Now, fast forward to 2020, the mindset of virtual care has completely changed, especially it changed with the arrival of COVID-19. Greater acceptance led to the need to expand telehealth offerings, which led to a greater opportunity of innovation. And then by 2020, the revenue in telehealth visits had then soared to approximately $30 billion in the United States. And we said back then that medical virtualists could be involved in a substantial portion of healthcare delivery for the next generation. So then in 2019, now this is before COVID, we launched the Center for Virtual Care with the goal of transforming healthcare delivery through innovation, technology, and collaboration. Now, this center that's known as the Center for Virtual Care is actually a physical location located in Midtown Manhattan on Lexington Avenue. And here we develop, evaluate, and teach new models of care that combine digital tools and virtual care. Now, since launching the Center for Virtual Care in 2019, we have trained over 4,000 students and clinical providers on the fundamentals of telemedicine. Now, one of our most recent accomplishments from the center was the official launch of our WP Carey Doctoring in the Digital Age Foundational Telemedicine course. So now, at NYP, New York Presbyterian, all interns and residents that start are now required to go through a telemedicine training through our Center for Virtual Care, where they're learning the foundations of telemedicine. We talk a lot about bedside manner, but it's also a lot more, especially when you're providing care virtually, you have to know appropriate website manner as well. Now, this makes us one of the only healthcare systems in the nation that provides foundational and formal training for trainees through our center. Now, within months of launching our Center for Virtual Care, then COVID arrived. Now, you can see from this chart that globally, the use of digital health services, now this is not just telemedicine, this is using all digital health platforms, apps, and other digital devices. Prior to the pandemic was around 365 million patients used digital care. And then at the peak of the pandemic, that more than doubled. And you can see that even post-pandemic, the number of digital health users continues to grow steadily. Now, I show you this to demonstrate that COVID really was a pivot point that forced us to push innovation and technology into different care models to keep up with the demand for more digital health options. Now, one thing we have to consider is, especially when it comes to telemedicine, within the next few weeks, the COVID-era Medicare reimbursements for virtual care that were granted through COVID and were extended actually expire at the end of this month. Now, we're hoping that these continue, but if there is a significant change, then that is certainly going to have an impact on usage in the long term for virtual care. But we're staying optimistic that provision will continue to some extent. So, how do we accelerate innovation when we're already facing challenges in the emergency department? Now, you heard my prior speaker talk about burnout, especially with clinicians in the emergency department. You know, we are the front door to the hospital. The majority of hospital admissions in a hospital actually come through the ER. We're also the safety net of healthcare. Now, if COVID didn't convince you that, I don't know what can. But really, we were the backbone of healthcare during the COVID pandemic. And because emergency medicine plays this role, we have a responsibility to ensure that our patients feel safe, are heard, and have the best experience possible. Now, COVID may no longer be the top issue confronting emergency departments today, but we're still up against a number of challenges. As I said, physician burnout, staffing shortages, which are still happening, patient boarding. So what is patient boarding? When you look at most emergency departments, not only in the city but in the country, people are waiting for beds to go upstairs because we just don't have the capacity. But these are some of the things we're facing. And finally, reimbursement. So I mentioned to you a little about telemedicine reimbursement. That's not it. That's not the only thing. You know, there are also potential cuts in Medicaid that are being proposed as well. All of these things, when you combine them, can overwhelm an already stressed system. So we have to really start looking at emergency care through a different lens. We know that care doesn't always have to take place in the emergency department or the hospital. Now, the past few years have shown us that telemedicine is widely accepted as a means of care delivery, and demand for it will likely continue to increase. While there will always be in-person visits that are required, it's important to develop virtual care options and a skill set to effectively serve our patients. Now, our department here at Weill Cornell Emergency Medicine is focused on expanding our hospital at home and remote patient monitoring programs. You'll be hearing about hospital home by Dr. Fertenko, who's speaking after me. But we really need to expand these programs. Both of these programs allow our patients to receive comprehensive care from the safety and comfort of their home. We also started to explore virtual and augmented reality in patient care, as well as in education. So you're going to see more and more of that being implemented. And of course, a discussion about the future of care would not be complete without a discussion about AI. And I'll talk a little more about AI's impact on emergency care. So what I want to discuss right now is one of our programs that has truly had a positive impact on patient care, our Community Teleparamedicine Program, or CTP. CTP is preventative emergency medicine that combines on-demand paramedic home visits supervised by emergency physicians via telemedicine with intensive case management by care managers. Now, once a patient has been discharged from the hospital, during the following days at home, they may require acute interventions or medication adjustments. And what usually happens to these patients? Once they're discharged from the hospital or discharged from the emergency department, they're told simply, go back to the hospital, go back to the ER, or be readmitted to the hospital. Now, as I said, this is truly preventative emergency care, and we've received overwhelmingly positive patient feedback. In fact, you'll see this article just last week was published in the New England Journal Catalyst on our program about how community teleparamedicine has been able to improve telehealth access for underserved populations. So now, you're going to probably ask, does CTP work? And we've now been doing this for several years. So CTP allows us to provide comprehensive, high-quality care for our highest risk, most vulnerable patients in the comfort of their own home. Now, patients in our program are racially, ethnically, and socioeconomically diverse. Our average age is 71, and 2/3 of our patients are non-white, and many of them are actually on government-sponsored programs like Medicaid and Medicare. Now, from a data perspective, we found significant reductions in ED revisits, hospital readmissions, and effectively creating more capacity and improving care. So I talked about patient boarding. I talked about capacity issues. If you could keep people in their houses, in their homes, and prevent them from coming back to the hospital, this will essentially create more capacity as well for others. And this program when we actually send, and I'm going to show you a video next, when we send these paramedics to their house, they actually perform meaningful interventions. What do I mean by that? They're not just going in there to check on them. They're actually doing EKGs. They're doing point-of-care labs. They're actually giving medications, readjusting their doses, and also taking medication histories. All of these things are essential in comprehensive care for these patients. So what I'd like to do is play a short video, which shows you how our community teleparamedicine works. Are you able to play the video?
The NYP Community Teleparamedicine Program combines paramedics' home visits with telemedicine to provide acute, unscheduled care throughout Brooklyn, the Bronx, Manhattan, and Queens.
Been taking all your medicines?
Yeah.
Okay, no changes, right?
No.
In the home, CTP performs a standardized assessment, including vital signs, physical exam, and cardiac monitoring. They ensure patients are taking the correct medications, review discharge instructions, provide disease education, and finally, using our telehealth equipment, initiate a virtual visit with an NYP emergency medicine doctor.
So Dr. Nayak, she's
Yeah, doctor.
Hello?
Hi, Dr. Nayak. She's looking pretty good. She's only complaining about that she's gained 2 pounds. However, she had lost 2 pounds.
Right.
If you, right?
I gained 2 pounds.
But if you look at her weight chart, she went from 157 to 155, and then came back up to 157.
Right.
So I gained 2 pounds.
And the last time we saw her, she was 158. So I'm not concerned about that.
Our emergency doctors can access all of the patient's health records, prescribe new medications electronically, direct the medics to administer medications in the home for current symptoms, or send referrals to other NYP specialists.
Let me just confirm the pharmacy. It's the Walgreens on 2nd Avenue?
Yeah.
Okay. So I'm sending the refill for the metoprolol there. She can keep using the Cepacol throat lozenges as she needs to for that tickle. And then just follow up with her doctors.
CTP coordinates outpatient care by sending visit summaries to the healthcare team, contacting their regular doctors during a visit if necessary, and helping to arrange for home services or transportation.
I'm happy to see what we're seeing. I think you're doing okay.
Thank you, doctor.
Ms. Forkowitz, it was a pleasure meeting you.
Thank you.
All right, you take care of yourself and we'll see you soon.
Okay.
Bye-bye.
Thank you. Bye-bye. Bye-bye.
Thank you, doctor. We'll give you an ETA when we have one.
CTP means preventative emergency medicine.
So I love that video. I've probably watched it about 100 times. But it really shows you the meaningful impact that this program has on our patients. Next slide. So I talked a little about AI, right? And you heard some presentations on AI. Going back to artificial intelligence and machine learning, so there are questions whether AI can be used in the emergency department now to enhance patient care, improve communication, also improving outcomes. And we're doing a significant amount of research in this area to get some of these answers. As Mr. Hartman had shown you earlier, we recently published our research on the value of using AI written handoff notes, especially in handoffs from ED to inpatient providers. AI also potentially may help to predict outcomes, diagnosis, and treatments, especially when time is of the essence. Now, the Cactus trial, which we're participating, is developing machine learning algorithms to identify undiagnosed structural heart disease in the ED. And one of our faculty members, Dr. Brock Daniels, who's serving as a site PI, is actually looking at this to see if this will have an impact on saving lives and identifying some of these patients. The other area that I'm very excited in is using AI potentially in triage. So we are in the midst of initiating a pilot utilizing AI for triage. Now, this is going to be a pilot, but we want to know, could AI help augment our triage processes? So, that's one area that we feel that it might have an impact. But I do want to stress that we have to be very careful. Obviously, we want to make sure we ensure privacy, patient safety, and make sure we're following good outcomes. So, how do we continue to advance the future of care? The future of care takes a village, not an individual. The one thing that we talk a lot about, and I'm a firm believer, is in this team science approach. We have to collaborate with others. You can't just do this in silos. For example, last week, that picture there, and we actually launched the Weill Cornell, one of the first of its kind health tech immersion program with Cornell Tech, where Weill Cornell emergency medicine faculty are collaborating with graduate students from Cornell Tech to bring their projects to completion. And that's the first step in a long-standing collaboration that we see with Cornell Tech. We also have many different industry partnerships also. As you saw, Abstractive Health, Vince Hartman was here. We're also partnering with other companies as well to see how we could actually improve care in the emergency setting. With that, I think we've come a long way. It's been 7 years since I was last here. But we welcome your thoughts and ideas on advancing future of care, future of emergency care. And please feel free to reach out to me with any questions or comments. Thank you very much.
Future of Care is New York City's premier community for healthcare innovation. To learn more, subscribe to our channel and visit our website at futureofcare.nyc.